I was pleased to and thankful to have this opportunity to speak about the work we do on the Joint Action on Cancer, which is, as the name says, a joint project of now 28 EU member states and Norway and Iceland. One of the topics that we are discussing in this project is the introduction and the implementation of national cancer plans. Of course, the challenge I was given by the organizers was, do these plans make any difference? Do they have an impact? So, what are national cancer plans? I'm sure most of you are familiar with the concept and probably have seen a few, at least those of your respective countries, and probably also some others. They are meant to be structured health policy documents, adopted in order to achieve a number of objectives and goals. One is to plan overall cancer management. I think that nobody else knows better than patients how important it is to cover the entire span of the disease. From its very beginnings, let's say also prevention and promotion, through screening, diagnosis and treatment, and then whatever the outcome, hopefully of course survival and victory over cancer, we have to have adequate activities and services available. Secondly, as Yola was referring to billions, of course resources are needed for cancer management. Sorry to say that unfortunately, as we live in these tough times, as also Mr. Lujan stressed, given the austerity and the financial pressures, cancer is of course an expensive disease, but it's even more expensive if we don't approach it properly, if we don't approach it in a structured way. It is also a disease that some of my colleagues now challenge and say, is it really a chronic disease? If somebody survives it, if somebody is in permanent remission, he or she is in a better shape than a diabetic patient or a patient with hypertension. I'm not saying, don't misunderstand me, that living with cancer, even after you have won the battle against it, is easy, or that you don't suffer the consequences. They may be multiple. I'm just saying that proper management of cancer gives you an opportunity that some of the other chronic patients don't have. Entire span of services. This is one of the points I will come back to with respect to many countries in Europe which are still lagging behind. And then, of course, and the last point is already one of the answers to your challenge. We have to monitor what we have done. There are several ways in which this can be achieved. We often quote WHO's definition because it encompasses the entire span of cancer plans, programs in their terminology. So, the first aim is of course to reduce cancer incidence and mortality, and then immediately followed by the quality of life, because it's not important only that we survive, but also the way we survive. Evidence-based strategies for prevention, early detection, diagnosis, treatment and palliation. I would add here something that I often miss in these listings, and that is rehabilitation and reintegration. Rehabilitation not in the minimal sense, but in the full sense. If somebody survived cancer, he or she has to return back to normal life in its fullest. Professionally, if it's a senior person, even in that capacity, of course, to normal life as much as possible. So this is the structure that WHO first proposed. We have prevention, we have early detection, we have diagnosis and treatment, pain relief and palliative care. As much as this fourth point seems natural, it is still sometimes an issue. Cancer control research and surveillance in cancer control, which one of the most important landmarks of surveillance are, of course, registries. So, how did we get to so much talk about national cancer plans? The European Union picked up the work on NCPs through the Council conclusions from the 10th of June of 2008, where there was a specific call on the member states to prepare these plans by the end of 2013. Some of you may know, and this is also the period when I think Viola and myself first got in touch. My country's, Slovenia's presidency to the Council of the European Union chose cancer as its main health topic. My task within this project was to evaluate what happened in this period, in these 4, now already 6 years. We have discovered that all member states but 4 managed to reach this target by 2011 already. There are 4 member states for various reasons. I've listed them because otherwise everybody asks me, which are they? There are different issues there. Austria and Luxembourg have been working a very, very long time. There are various reasons why they haven't reached the final goal. Bulgaria started seriously last year. In Slovakia, there were some issues I heard from the colleagues that in the policy-making process that prevented this from being adopted. But they all have started working on this. Of course, one thing that we cannot deny, those countries who enjoy the highest standard of living in the EU also commonly and most frequently have the best structured services. Of course, some may ask and say, well, it's easy to wrap up a nice document, but what does this really mean in practice? We can write a nice document and then live a completely different reality. Fortunately, that's not entirely true because there is evidence to support this. Fight against cancer, as I mentioned here, is also about mobilization of resources. So not only financial, but also human. And not only doctors and not only nurses, but a whole range of professionals who have to be involved in the management of cancer. Small member states have a certain handicap at this point, not only those who are maybe lagging behind economically. And now we are at the survival of patients. This was our primary objective always, and still is and will be for the future. And now we have to redefine our approaches in the societies, I would say. I think there is still too much stigma attached to cancer. So a survivor still faces a series of problems, whether it is someone who had a childhood cancer, adult age. I'm sure that all of those of you who are cancer survivors have a lot to say about this. But the fact is that all of us have a duty to restructure the views of the society. If I remember my early student days as a medical student, the same was happening to cardiac patients maybe 30, 35 years ago. When somebody had a heart attack, they said, well, you go home and rest. And only later they realized that, of course, continuous physical activity was important in survival and in maintaining the positive results. Active life needs to be supported, and psychosocial support is essential there. I think Barbara's story adds a very important bracket there, although I will return to her story in another topic which is extremely important to me. So where do we see benefits of national cancer plans for patients and the populations at large? First of all, there is a general benefit that when you prepare such a document, and I'm sure you're well aware of that, in a political setting, in a policy setting, there is attention to it. Of course, because cancer is already getting a lot of attention, but when you are preparing such a document, it's always an additional point in favor. There is political motivation, action to secure resources. I think this is very important, and I think that much has been done in this sense. Something that we all aim at and hope for is the convergence of services across countries, regions, and EU. I, as a believer in a multi-country and EU cooperation, I strongly believe that networks and centers of excellence can help out improve overall quality of services in our respective countries. They need not to be one-way roads, patients just streamlined to those centers, but also being centers of excellence in educating professionals. The fourth point seems maybe quite evident. For many of you might seem, well, of course we need a structured and transparent definition. But as I mentioned, rehabilitation, even palliative care, whenever we come back to it and we screen the national cancer plans, and palliative care is still missing in about 8 or 9 cancer plans across EU member states. Why? When we know that a number of patients really badly need this type of care. Monitoring and evaluation. This is not only monitoring mortality and survival and 5-year survival rates, but of course it's also about monitoring the quality of services and the quality of life. This has to be followed by the comparable indicators and outcomes. So the preparation of a national cancer plan is also an opportunity that we go through and look what we have missed in the past. Our aim from the project, I think it's important to say this at this point, is to propose a guide. We wouldn't call it a guideline, but a guide for member states on how to prepare a good quality cancer plan, so that all countries would have palliative care, that all countries would have patient participation and involvement, that all countries would have rehabilitation, and that all the services that are part of a comprehensive cancer management structure have to be addressed. Of course, there is a standardization of activities. In our future joint action, we want to work on another important topic. Two important topics. One is survivorship. This term is gaining in importance. And because there are more and more cancer survivors, they are facing more and more challenges, and there is more and more work ahead of us. And the second thing is healthcare is becoming optimized. It's becoming very focused, especially hospital care, highly specialized care. And patients return to their homes, to their normal environments, but care continues. And primary care and community care has a very important role in that respect, to maintain that focus on the patient's continued involvement. The research aspects are important as well. In conclusions, I would like to say that I was trying to list some of the important arguments why national cancer plans are an important contributor to transparent, organized, and managed efforts of modern societies. Integration is an important factor and cornerstone for this process. Adequate allocation of resources is vital. Cancer teams at all levels of care have to be clearly defined and identified and qualified, of course. Final ultimate goal would be that we will have converging services across Europe that can improve survival, quality of life, rehabilitation and full reintegration of cancer patients. With these final words, I thank you for your attention and again for your invitation to this important event, and I'm open for your questions when time comes. Yes, I just have to. Yes, no problem. I'm used to these situations, so I would like to invite Dr. Tomáš Pavlik from the Czech Republic, a biostatistician from the Institute of Biostatistics and Analysis at the Masaryk University in Brno, who will speak about an important factor in monitoring and following up of cancer developments, and that's about cancer registries. The floor is yours.
Thank you for a kind introduction. Also, I would like to thank for inviting me for this very friendly conference. And I would like to apologize my boss, Dr. Dušek, who was primarily nominated for this speech and who cannot be here due to some severe family troubles. Instead of him, I will say to you something about the Czech information system for assessment of cancer care data. First, I would like to introduce myself a bit. I'm not a clinician, I'm not a patient, I'm not a politician, I'm a biostatistician. So I'm a bit like a white crow here, but I think, or I hope that it will not matter. And I will show you some data and some outcomes that might be interesting for you. I will show you the Czech way. Regarding the outline of my presentation, I will first focus on the general structure of our system. Then I will say what kind of information can we derive from the system. And at the end, I will show you some real examples on data, on colorectal cancer data. The primary question is, why do we need clinical registries? And the answer is quite simple, at least in my country. The answer is know that there is no centralization of cancer care data in the Czech Republic. Moreover, the individual data sources that are located in our healthcare system are not properly communicating with each other. So you have some sort of information here, another sort of information you have there, and if you want to identify or analyze some kind of useful information, you need to combine multiple sources. And so there's a way, or you need to have specialized clinical registries to combine, integrate information to be able to get some useful answers to your questions. The primary structure of the Czech system combines three layers or three forms of data sources. The first, on the top, is the layer combining, or it's a layer of population-based data. In oncology, it's namely the Czech National Cancer Registry that provides information on cancer burden at the population level. Second, we have hospital-based and specialized databases that aims at some specific areas of cancer care. And third layer represents administrative data from health insurance companies that comprise information on individual treatments or individual patients and their treatment. And having all these information sources, you can assess almost all aspects of cancer care. But it would be naive to presume that the whole system is only about databases and data collection. The whole system is based predominantly on data integration and about what we call an analytic layer, which is here represented with, it's a nasty word, data warehouse, which is not only about collecting and typing data using keyboards, it's about merging, analyzing, transforming, and customizing the data to be able to answer specific questions in cancer care. Here I have a real example of those three layers that form an information support for our colorectal cancer screening program. You see three boxes. These are these three layers I mentioned before. First, on the top, you have the Czech National Cancer Registry, where you can find data on all colorectal cancer patients diagnosed since 1977. Second, you have a specialized database of Czech National Colorectal Cancer Screening Database. There you can find data on preventive colonoscopies in the Czech Republic. And third, you have administrative data from health insurance companies where you can find information or data about persons who underwent FOBTs. Of course, if you want to work with patient data, you need to guarantee their security. So it is inevitable to have security management guidelines to provide the highest possible information security. Our institute holds three ISO certificates, and Dr. Dušek is especially proud of this slide because of the ISO 27000, because we are one of the few academic institutes in Europe, maybe the only one, who holds the ISO on the information security management. Just to show you that the system or the specialized clinical registries can be general and flexible, I would like to only mention that our system is providing support to more than 150 projects in various fields, from medicine to environmental sciences. And what kind of information are we able to derive from such a huge amount of data? Generally speaking, we have to cover all main dimensions of patient information and his fate during or in the healthcare system. First, we have on this axis, we have patient and tumor characteristics, or the characteristics of patient and his disease. Second, we need to have follow-up information. We have information on treatment, relapses, progressions, and whatever happened to the patient in time. And what's also important are the costs. Because if you have costs, you can also assess the financial aspects of cancer care. To be more concrete, here you have some real examples of what are we able to monitor and assess in our databases. This is the layer 1, and these two are from the layer 2, hospital-based data and specialized registries. For example, we can assess patient survival, which on one hand can be regarded as a safety measure, for example, in surgical oncology in form of 1-year mortality, and on the other hand, it can be regarded also as an efficacy measure. And here I mean mainly the overall survival, relative survival, and so on. On the other hand, you can also evaluate quality of life, but you first need to have data on quality of life, because you are not able to easily find information on quality of life in population-based or hospital-based databases. You need to have specialized clinical registry to collect and further evaluate quality of life data. Now I will show you the 3 examples coming up from the mentioned 3 layers. First example will be from the Czech National Cancer Registry. Second example, I will show you how we are able to monitor the performance of our colorectal cancer screening program. And third example will be the results from the Czech registry for monitoring of targeted therapy in colorectal cancer. So first, I will show you some figures from the Czech National Cancer Registry. We are able to monitor time trends in all main cancer epidemiology characteristics, including incidence, mortality, prevalence, and even survival. Moreover, we are also able to monitor trends in stage distribution, which, especially in the Czech Republic, it's not very positive, because we still have, even in 2010, we still have more than 50% of patients diagnosed with stage 3 plus colorectal cancer. And we are able to monitor and evaluate the past, but we are also able to predict colorectal cancer burden to the future. And we are able to predict both population and therapeutic level. So these predictions are based on the past information, but we are also able to provide some future progress or some insight on future progress on the burden in the Czech Republic. As I said before, we are combining all 3 information layers to be able to identify or evaluate individual steps in our colorectal cancer screening program. We are using the data to evaluate FOBTs, colonoscopies, and also the diagnosed cancers. And given these data, we are able to monitor trends in screening coverage, as well as disparities in screening coverage across the regions in Czech Republic. And we are also able to evaluate the performance to make the quality assurance, quality control, especially focused on false positive and false negative rates. In 2005, the Czech Society for Oncology started a clinical registry for monitoring targeted therapy in colorectal cancer. In 2005, it was focused on bevacizumab administration in the Czech Republic. And currently, the registry is monitoring 4 drugs for targeted therapies in colorectal cancer. And here you also can see some practical results that we are able to monitor, evaluate. We can have, or we can monitor prevalence and incidence of treated patients. We can evaluate their outcomes, survival outcomes, safety measures, and we can also evaluate disparities in bevacizumab administration across the Czech regions. The registries are not only for collecting data, as I said before, but they also need to have some scientific impact, something in a paper form, and we are doing our best to have our results published in both regional and international journals. And I hope that these publications, or the number of publications, will grow up in the future. And at the end of my presentation, I would also like to show you that some of the results regarding the Czech epidemiology, cancer epidemiology, are also publicly available, so you can use internet and visualize cancer epidemiology in the Czech Republic at your home. First, I should mention the project SVOD. It's a system for visualization of oncology data, www.svod.cz, where you can find the basic information on cancer epidemiology in the Czech Republic. You can see the trends since 1977. You can see the trends in incidence, mortality, stage distribution. You can see the regionally specific incidence of cancers in the Czech Republic. I should also mention that this portal is not only focused on colorectal cancer, but it comprises data on all solid cancers. And also you can find there international comparisons or international statistics. And at the very end, I would like also to show that 3 web portals, including information on performance and outcomes of all 3 screening programs in the Czech Republic, are publicly available. And before I thank you for your attention, I would like to say that I have shown you a lot of figures, but we need also some kind of action, because otherwise it would be only figures. So I am very pleased that Mr. Luhan was here, because now it's his job to take the data, take the information, and make it or transform it into some kind of action. I thank you for your attention.
Thank you, Dr. Pavlik, and thank you also for keeping extremely to time. I would like to invite now a surgeon, Dr. Petra Boelens from Leiden, from the Netherlands, who is going to speak about another important topic, which is about multidisciplinary teams and treatment guidelines.
First of all, I would like to thank the organization for inviting me. I think it's a big honor to be here and to be able to share some slides that are a little bit a lot, so I'll try to keep in time as well. This is it. Is it on? Okay. MDTs is for multidisciplinary teams, and treatment guidelines influence their outcome for patients. We all want to have the best results for our patients, and there is still variation in outcome of colorectal cancer care in Europe, and I will show you in the next slides. I myself am a research fellow at the Leiden University for the EURECA project, and EURECA stands for European Registration of Cancer Care. It aims to reduce this variance in outcome for patients with colorectal cancer. One of the main points that we are working on is, so what is good colorectal cancer care? We need to look more at definitions, and we should look for more patient-related input in this. I will shortly say something about guidelines formation and about multidisciplinary teams. A little bit back in history, just as an example, before the 1990s, local recurrence of rectal cancer was very high. unacceptable high, about 20 to 60% in some hospitals. Since then, a lot of improvement has been done, and standardizing surgical techniques is one that improved a lot. Applying radiation therapy in rectal cancer has done a lot. Chemotherapy in colon cancer has done a lot. Pathology standardization, radiology, more advanced techniques to diagnose and to restage disease have improved where we're looking at and what we can do. Besides that, a lot of audits and registries are giving us back information about our performance as doctors, which is very important. I'll get back to that, of course, later. Guidelines and NDTs. This is just an example that, as you look in the time frame from 1975 to 2010, different European countries, mortality trends, and you can see there's a lot happening, and there's a lot what we can see to find out why some countries have other numbers than other countries, and some can be improved. Another just an example to show all these bars are different countries in Europe. As you can see on the left side is rectal cancer, on the other side is colon cancer. There's a lot of variation. It varies from 60 to less than 40% in 5 years survival of these two cancers. So there are a lot of differences in outcome after treatment of for colorectal cancer. And it's wide international variation. It's not just in, between high income and low income countries, but also within high income countries. As you can see from this study, in Australia, Canada, Denmark, Norway, Sweden, UK, all high income countries, and there's a lot of variation also in between those countries, and even within countries in outcome. So do we strive for no variation? Well, that is simply not possible, and I will explain why. Each patient is different. We have different genetic backgrounds, we have a different tumor anatomy and tumor biology. One tumor is more aggressive than the other. Comorbidities, it's a disease with a peak incidence at older age, so people have comorbidities, different kinds. Lifestyles, some people smoke, some people do not smoke, with different lifestyles, all matter. And patient preferences. Some patients want everything, and some patients just want the basic. So this all combined we call random variation, and that is not something we are likely as doctors, as teams to change. So there are some things we can't change. We can't change the genetic background, for example. Of course, patients can change their lifestyles, but not when you are diagnosed. You can change your lifestyle, what you did before. So we need to reduce the systematic variation due to the differences in policies, health policies, and the treatment strategies doctors apply. So what endpoints defines good care? Well, traditionally we're looking at survival, which could be divided in overall survival and disease-free survival. And more modern is, of course, quality of life. There are not so many registries at this moment, or audits at this moment, that really actually register this quality of life. And functional outcomes, there are just a handful of clinical papers that report on outcomes such as sexual function, urinary function, gastrointestinal function. Not enough. And what about the patient preferences? Were they part of the medical decision making? Also, not enough. We need to do more there. Your treatment, your goals. I took this picture. We need, as doctors, more patient interaction in decision making and in defining what do we really care about, and how can we modernize our definition of quality of care. And then we want to go from variation to reduced variation to transparency. Can we look at numbers and see what is happening in a certain country? Do they give good quality of care? We go from generalized data, usually averages from a certain selection of patients, to tailor-made cancer management. It's a difficult step to do that. And if we go to tailor-made cancer management, how do we monitor that? And how can we still see whether it was a high-quality kind of cancer care? So these are just thoughts to keep in mind. And we need patients also to give back this information. And we need to find out how to monitor this. Are we good doctors? Of course we think we are that line. Very good. But it's very important to look in a good mirror and see what you are actually doing. What is your performance? To become a better doctor, we need to look at patient data. And we also need to feedback in a non-blaming environment among colleagues. So we need good monitoring and auditing. Auditing is the instrument to give the feedback in a positive and constructive way. We do know that high volume centers produce good quality, but we also need to improve quality in low volume centers. Not all of Europe is, it is possible to form high volume centers. And we need to keep ahead of science, keep up with it, and form up-to-date guidelines. Research that was mentioned before, I will come back to it later. We need to learn from best practices, and we need to train the ones that need to be trained. The mission of the European Cancer Organization is every patient deserves the best care there is, and gives us the question, what is the best care there is? And there's a dynamic field of knowledge, and proof is not always strong proof. So there are different ways of qualifying evidence-based medicine, and therefore we need experts to lead the way in formation of the guidelines. As you can see, it's not always as clear. We do know that if you are not measuring or registering anything, you don't know how you're doing. And we need to identify the best and the bad. That's why we have this Eureka project for registration of cancer care, which is an ECHO and ESSO initiative. And we would like to have one European cancer audit to identify the best practices, to do research on currently available registries, and give an outcome monitoring with feedback as a true auditing. And of course, we also involved in guideline development. Okay, that's how we'll go. So we will find out which one we are. The thing about guideline formation is everyone derives from the same pool of scientific evidence, but everybody looks at it from their own medical structure. And so there are many different national guidelines, and everybody is taught a certain way to become a certain physician, and explains the proofs differently. That's why it's so important to have consensus meetings of international experts of all different fields of cancer care to interact and to give the best standards so that we can communicate this with everybody. And that is, well, these I'm going to skip because I already told you. So we had a consensus conference just in December 2012 for colon and rectum, multidisciplinary. We used the Delphi method, which means that you have this expert panel, international experts, leaders in the field, on diagnostics and treatments. many statements, almost 500, and several voting rounds to establish minimal standards of good cancer care for colorectal cancer patients. Many affiliated societies were present and worked with us, also with Dr. Colum and nursing liaisons. Just a short result, formed 65 statements. 75 of the experts voted on all these statements. Not everybody could vote on everything because that was not their field of expertise. And we had 84% large consensus, which means that more than 80% of the experts agreed on that sentence. This information is in the press and we're working on a patient version. This is just an example of one of the algorithms, the flowcharts that we made for example, diagnosis of colon cancer, which stage, what should be done, what treatments should be recommended. This is one of the new papers to be distributed. It should form a basis for diagnosis, staging, and treatment guidelines in Europe. It should support MDTs in medical decision making, as I said before, to be published soon. The MDTs, there's a certain notes on that. MDTs are very important and should contain different doctors. It should have radiation oncologists, medical oncologists, gastroenterologists, surgeons, pathologists, radiologists, and nurse specialists. And they should come together at several points in time. Of course, they should discuss all new patients with cancer, but they should also discuss what is happening during an intervention, whether it's surgery or whether it's radiation therapy after restaging. It stays very difficult to prove. There's few studies that are well designed, so we have weak proof that MDTs work, but we know that it is a very good matter of quality control among a group. And as a surgeon, I don't know everything about medical oncology. The medical oncologist doesn't know everything about us in surgery. So we need to interact, and this is a good day also to interact. There are hazards and they are well known. Time pressure. Some MDTs only have half an hour to discuss 25 patients. You can see that's quite ridiculous. There's reduced attendance. If I'm doing the surgery and one of my other colleagues is not attending the MDT, it's not a surgery. There's quite some organizational problems. Sometimes there's disagreement within MDTs. Different kinds of doctors have a different view and they can disagree. Sometimes there's a lack of open environment for discussion, which you can find in any kind of team. That's why there are many hazards, but I feel we should look for that we have better MDT discussions. Take-home messages of my talk are anonymous patient data, very, very, very important for monitoring the quality of cancer care, showing the doctors where to improve, showing hospitals where to improve, showing where to be more cost effectiveness. Anonymous patient data should be collected to learn from what we do with diagnostic processes and treatment decisions, and also with terms of outcome. Patient versions of guidelines and consensus documents should be available for medical decision making for the patients and the doctors. And every patient should be discussed in MDT sessions, preferably several. The MDT should adhere to the latest guidelines and consensus documents. And if they do not, they should discuss that very carefully with the patient and describe it in the patient records. And medical decision making should always be shared decision making between the patient and his and the physician. That's my personal words. Thank you.
Thank you, Dr. Boulens, for this last. The control. Anyway, I think it's time for questions and for discussion for all three of us. So we are ready. We're here. The floor is open. Yes.
When you were talking about national cancer plans,
There is one.
right, in national cancer plans, are you of the opinion that patients should be involved in writing national cancer plans? And are they being invited? Because at the end of the day, it involves them. And so I'm really keen to know where we're getting with that.
My view is that they have two roles. They have to participate actively in writing a cancer plan, and then secondly, they should revise it as well. And I think patients should be on a sort of a panel that will later, once the plan is being implemented, also evaluate its advances, because the advances are again measured also by patients' experiences, not only by epidemiological and clinical criteria. So I perfectly agree with you, and I think this is one of the points that we are going to try to put into this guide for cancer plans.
Thank you. Sorry, something else I'd like to ask. Can we use this? Because there has to be a report that will be sent to the Commission from this meeting. Would it be okay by you if we were to say in this report that there was an agreement on the fact that patients should be integrated into writing national cancer plans? Or can we have a vote amongst the patients?
I would be more than grateful if this is possible.
Can I just make a comment on that? I absolutely agree that patients should be involved. I think before one has a vote on agreement, I think we'd actually need to discuss how that's possible, because what often happens becomes very tokenistic, and I think there needs to be, if you're going to recommend patient involvement in both the drafting and the review of cancer plans, one needs practical solutions about how to meaningfully engage, not in a tokenistic way.
If I can share the Cyprus experience, we have managed to participate in the National Cancer Committee, which was responsible for drafting the National Cancer Plan. So from the different 3-4 cancer associations, amongst themselves they selected one representative from cancer patients' organizations to participate in the committee. And the committee drafted the plan, etc. But the problem now is in affecting this plan. And because there are problems further on with the committee working and putting into action the plan. But one way is the participation.
Which country?
Cyprus.
Cyprus, okay.
But one way is to be part of the body that will draft the national plan, whichever is possible.
But sorry about that. But I would like an in-principle agreement. Shall we have an in-principle agreement rather than a consensus agreement? Shall we have an in-principle agreement? Do patient organisations and patients present here, in principle, agree that we should be involved in National Cancer Plan writing? How that will be affected would be something that would obviously need to be addressed. But could we have a show of hands for in principle? So what would be interesting is to address the people who don't think it's a good idea. Wolfram, why do you not think it's a good idea to be involved in the writing of a National Cancer Plan?
I'm fully convinced that the National Cancer Plan is of paramount importance. And I saw the trouble which we had in Germany. You know, Germany is divided in 16 states, and to coordinate these 16 with own governments, and in excess of that, 16 health ministries. So it took a long time. It was, I think, only last year that we started with the National Cancer Plan. It was nothing new for us, because I read in history, 1923 already, the Senate of Hamburg, they initiated a cancer plan. That's the longest one. But Germany has a problem with data collection, and because I think it comes out of history, especially when it comes to collecting data about individual health. So it dates back to the very, very bad times which had to live up in the 30s and 40s of the last century.
So, sorry, can I just comment there? I'm not sure if you fully understood Yola's question, Wolfram. Do you think that patients should not have any involvement in the creation of a national cancer plan?
Yes.
I think that we can safely say that there is a, in principle, agreement that from this conference that patients should be involved in contributing to national cancer plans, but that one would have to address how this could be done.
Yes, I think that definitely. I think modalities, as the gentleman from Germany stressed, the modalities depend also, I'm afraid I have to say this again, also on health systems, because there are some specifics already how patients are involved in general in a particular country, not only cancer patients, but patients in general. Of course, cancer patients can have a lead on that. And secondly, may I just comment, I'm sorry for taking up so much time on the plans. The federal European states, member states, countries, have a double challenge. One has been nicely described on the example of Germany, but of course they have also positive examples of their regions. In Germany, some are the size of countries. How to approach problems and successfully being managed. And that's not only Germany, there's also the example of the country we are in, Italy, UK, and so on. So there are all sorts of problems. But I'm grateful for this support, because I think that now that we are entering the final stages, and of course patients are going to be invited, and I extend my invitation again also to the open forum, the main event of the joint action, which will take place at the end of November this year in Slovenia, actually in Ljubljana, and cancer plans are one of the two topics.
Excellent, thank you. I also wanted to mention, oh, sorry.
Joni Bond from the Netherlands. I have a question for Dr. Bullens. First, you spoke of the conference in December from the expert panel. Were the patients involved?
Yes, Europe Colon was involved.
Okay, thank you. And you spoke also about shared decision making.
Yes.
Well, fortunately, I live in a country which is going to do it. But in order to make shared decisions, the patient has to know. And who is telling the patient the good things and the bad things to make a shared decision?
Yeah.
That's for other countries, I think, very important.
I think there's still a large job ahead in training physicians to really be involved in shared decision making, not just from a doctor to a patient giving the information about the disease and what they think is good for them, but really objectively going into a dialogue about all the pros and cons of each kind of treatment and diagnostic process that involves the patient, so the patient is more involved in the medical decision making. It's not happening yet at many patient-doctor interactions in the Netherlands, I know, but I'm one of the few trying to change that. I think this is what I also meant with we need more patient interaction. We need to educate not just the patient, we also need to educate the doctor that he needs to not bring a message, but listen to the patient and work with this new information because we're not trained to do so. Yeah.
I have one question to Dr. Albrecht. If I see my German patient card, or it means health card, plastic, with an electronic chip on it, but this chip is almost empty. It contains my name and it contains the name of the health insurance and the birth date or something like that. Do you think if this chip would be filled with patient data, analytic patient data, as it is supposed to, but which is not done out of reasons which I made allusion to, do you think that this could also help in establishment of a cancer registry?
I personally believe that cancer registries are essential, of course, for monitoring of any kind of continued longitudinal patient activity. In cancer, this is, of course, because of its course, because of its nature, this is even much more important. We've heard the colleague from the Czech Republic saying that they have a 36-year long stock of data on patients with cancer. That is very precious. In Slovenia, our cancer registry was established in 1950. So this is very important. We know why the German situation is such as it is. And I think that generally speaking, politicians are more afraid of data privacy regarding patients than patients themselves in the first place, because knowledge about the disease and not only spreading it but also analyzing it in a structured way is a tool also for decision making after all. So of course, and it starts from an individual. We cannot just merge all the data into a mass. And I'm sure that the physicians present will agree with me that at the beginning, because I was working as a practical doctor at the beginning of my career, at the beginning the patient wants to know basically only two things. Is there a cure for my cancer? And what is the survival outlook? Then we come to the options for treatment and so on and so forth. And if we don't have a cancer registry, we can't competently answer these two very important questions. We can just estimate, or the hospital can estimate, because it will have at least a clinical registry, of course. They they will have one. So I think that inclusion of data with patient approval, which is, I think in the Czech Republic, maybe you should comment on this, because I think you established a system where patients can give approval to the processing.
It's a bit different.
But you can comment. Maybe it could be a lead to that.
Yeah. Thank you for the question. Maybe I should start. It's a little bit absurd, but the long history of our Czech National Cancer Registry is due to the communist regime, because it was obligatory to record patients. There was no democracy in this, so we were now thinking it was quite a good idea. About the patient information, the patients are not giving approval for using the data because some data are available at the population level. It's obligatory from the law, and they are de-identified data. All data we have at IVA are de-identified, anonymous.
But they are based on individual cases.
Yeah, they are based on individual cases. But sometimes we can start a project, for example, with some particular hospital, and we can analyze their data because in the Czech Republic, hospitals are the owners of patient data, of data about the treatment that was administered in the hospital. So we can use the patient data, of course, also in the anonymized form, and we can do quite a complicated analysis on the patient level. But if all the data are anonymized or de-identified.
So the final message for me would be, of course, we have to try to convince the politicians to pass the legislation that permits this kind of data collection, because it's probably less controversial than any other data collection at a personal level, at the state level. Other questions?
Yes. Can I would like to ask Dr. Pavlik if you know also the percentage of participation of the screening in the Czech Republic.
I'm not an expert on the screening, but it was on my slide. It's I don't know, in the colorectal cancer it's not very high, because it's quite a difference between having screening and having effective screening. So I think it's about 20%, but it's getting higher due to some actions in the last years that took place in the Czech Republic, especially some information conferences for general practitioners and also for the public sector. So we are doing better, but it's still quite a long way ahead of us.
Thank you. Yes?
I will ask you, Dr. Albert, do you have any feedback from member states that they have already cancer plans? How will they succeed in their or so on?
Thank you for the question. Some countries that have a long-standing tradition in cancer plans, I would mention in particular France, UK, and Netherlands, have a very structured monitoring system. I think the Netherlands has a traffic light system to monitor which activity and which service has been implemented or is in phase of implementation or is still under preparation or something like that. Belgium has recently had a comprehensive evaluation of the National Cancer Plan from the previous period. I forgot to mention, and I should add this, that most of the cancer plans were adopted after 2008. between 2008 and 2010. So for a lot of activities there was too little time to see. Another problem in evaluation of national cancer plans is that some of them are intended for a relatively short period of time, like 3 years, and some even for 7 years. I think that those who decided for 7 years were quite bold because they managed to convince the politicians to go beyond a single term of government and look for a long-term perspective. Generally, the successes of those countries that have improved their outcomes through these organized efforts have convinced also other countries who were probably hesitating a little bit on these activities. What we still lack overall in most of the countries is a clear dedication, transparent dedication of resources. And I'm not speaking only of financial resources, but also of human resources for the management of cancer. And so they often are becoming evasive. They say, well, yes, these are the professionals who already work there, screening programs have already been established and so on, but only if they are earmarked, they will stay, especially in the times like this. If you have this as a part of some global budgets, they may become reduced alongside with other things. And I think that that's one of the main assurances for the long-term strategies in cancer.
A short question for Peter Borens. How do you comment on small volume hospitals dealing with cancer?
Sorry, I missed a little part of your question.
What about small volume hospitals when dealing with cancer patients? And guidelines and
if good care is given, small volume hospitals do have a right to be there. But we do need to monitor each center for quality. And in some countries, geography will demand sometimes small centers in some areas to deliver certain care. And in other countries like the Netherlands, it's not so big. You could have more high volume centers to raise the expertise also on the rare occurrences that appear in certain cancers.
But what about a multidisciplinary team if you don't have a radiotherapy unit in your hospital? So I think it's a real problem.
Absolutely. Yes. That's why we have those consensus meetings to establish a certain minimal requirements for good care. And for example, for rectal cancer, radiotherapy is definitely minimal required part of the care. Not for all stages, of course, but...
Petra, I'm going to hit you with one other awkward question. For so many years now, I've been hearing there must be better doctor-patient communication, better doctor-patient communication. But what is actually being done about it? Are the younger doctors having something in their curriculum that will help this? Are there some training sessions? And above all, are we going to have it in a consensus document, or if we're going to give some guidance, that this has got to start happening, because it's not happening?
I can only speak from my own experience and from what I've seen in the Netherlands. Certain key surgeons, I'm just speaking about surgeons here, that I know in colorectal cancer have picked up this term shared decision making, and they are spreading the word. I think that is the best way how leaders in surgery start to train a certain new approach, because although it sounds very obvious to do, it's new. And so we will have better doctors. But it's nothing structural, it is not in the guidelines yet. I'm fully agreeing that we're just starting to grasp this approach, and that we definitely need more patient interaction to get this to a better level.
Such a wonderful opportunity with this document to integrate it into this document, because it's not just about the Netherlands, it's about the rest of Europe. And if it's in the guidelines that some kind of education has to happen, otherwise it's never going to happen.
Yeah.
You have this amazing document which we've been involved in, and many hours have been spent by such high-level people. It would be great to see that in the document. Can I park that one with you?
Oh, definitely. Yeah, I've spent a careful paragraph on it, but I will elaborate on it.
Can I just say what happened in my particular case, because it was fantastic. The decision for resection was made at a multidisciplinary team meeting, and there was a palliative nurse who reported back to me every time my case was discussed at an MDT meeting, and I also reacted with that, and she had daily communication with all the clinicians involved, and I pressed her, am I going to be discussed? So even if she didn't ring me, I rang her. And I think this is where the patient can be involved. And if that practice could be put into general practice, wouldn't it be fantastic?
Sorry, I'll get here as quick as I can.
I don't know, it's a suggestion. I don't know if it's possible to include this parameter, this communication between the patient and the doctor, in the medical audit, in the quality audit.
But every doctor will say that they are applying shared decision making, because it's the concept.
Yes, but in the audit don't the comments of the patients get put down?
A lot of audits are being filled in by doctors.
I'm Marta from Slovenia. I was patient 10 years now, and I'm survived, I think. But I changed my life a lot. And Mr. Albert talked about a lack of money and lack of resource, lack of human resources. And even we talk about it a lot, we never think that patient is body and the soul, the feelings, and it is most important in healing patient. So I think that in this plan we should put also this part of patient life. We are not just the bodies. And someone must start it with this. And maybe this compresses this one sentence.
Fully agree.
One more question, Yola. I think Deborah wanted to make a remark.
I just want to pick up this thing about shared decision making, and I suppose I think it's really vital. There have been movements in the UK in terms of training clinicians on communicating better with patients, and this research is very much alive, and Barbara's case is a good one. But I think it's also really important to note that Barbara is a very bright, articulate, educated woman, and that is not everybody. And I think there's one of the challenges for us also as patient organisations and people working with patients to think, how do we support and empower patients to take an active part, because as your title of your conference is, it's your life, your responsibility. And actually we have to be aware that there are people with very low levels of literacy and health literacy, and there's a really big challenge here for us to face to make shared decision making a reality. And I just want to follow up and just say I completely agree with our colleague Ms. Wiener, actually the whole psychosocial aspects of treatment care at every stage of that pathway, including post-treatment and survivorship phase, is absolutely vital, and we must do more. It's totally neglect.
I think we have an outcome. Patient voices saying we need to put in place. I think we're not just saying that it's about a one-way street. It's not just the clinicians who have to communicate. What we're saying is we have to teach our patients how to communicate, and clinical guidance has to show clinicians how to communicate. So we're going to start doing our work. So I'm expecting you to start doing your work too. I'm handing back. Thank you.
Thank you very much for this positive, positive end thoughts. And I think we have some nice recommendations for our common work and objectives. And I thank you all. First of all, speakers. Thank you for big thanks for the organizers for inviting us, and for all of you contributing to the nice debate we had. Thank you very much.